Thyroid glands, hyper and hypothyroidism. The function of the thyroid gland is to take iodine found in many foods and convert it into thyroid hormones, thyroxine T4 and triiodothyronine T3. Regulates metabolism, affects all cells' metabolism. It is critical gland for the body functions. We have the picture here with the pituitary gland that puts out the TSH down to the thyroid. That thyroid stimulates T3, T4. Hypothalamus that secretes the TRH, thyroid releasing hormone, that tells the pituitary to release TSH, thyroid stimulating hormone, which stimulates the thyroid to release T3 and T4. Negative feedback loop causes the anterior pituitary to release thyroid stimulating hormone to anterior pituitary to get the thyroid gland to secrete additional release of additional thyroxine. When circulating thyroxine levels are too high, this stimulates the anterior pituitary to decrease production of TSH, thereby reducing and causes amount of thyroid hormone in the blood. There are multiple causes of hyperthyroidism. We're going on to slide 5. What are the causes of hyperthyroidism? Too much hormone produced, T3 and T4 in the thyroid. Causes are Graves' disease, aka toxic diffuse goiter. Graves is an autoimmune disorder resulting from Hashimoto's thyroiditis, which results in autoantibodies to different substances and structures in the thyroid gland. Autoantibodies attach to receptors on thyroid gland. This reduces glandular cells and overproduces thyroid hormones. Multiple thyroid nodules, aka toxic multinodular goiter. Tissues or benign tumors, also known as adenomas. Patients with this type of hyperthyroidism for years, the goiter is going on for years and symptoms are milder and do not have exophthalmos or pretibial myedema. Everything is sped up with hyperthyroidism. You have heat intolerance, nervous, respirations are rapid and shallow, breathless, increased bowel movements, do not have periods, decreased libido and fatigue, excessive use of thyroid replacement hormones, aka exogenous hyperthyroidism. That's what that's called. Assessment findings for a client with hyperthyroidism: heat intolerance, nervousness, insomnia, rapid shallow respirations, breathlessness, increased bowel movements, amenorrhea, decreased libido, fatigue. See Iggy chart 63-1, page 1265. CV issues would be dysrhythmias, increased systolic blood pressure, widened pulse pressure, tachycardias, palpitations, and chest pain. Trembling hands, weight loss, muscle weakness, warm, moist skin, hair loss, staring gaze with hyperthyroidism. It looks like they are bipolar. Everything is sped up with hyperthyroidism. This is a picture of a goiter, the really big neck, thyroid gland, swollen. Additional assessment findings for a client with hyperthyroidism. Manifestations include goiter, exophthalmos, pretibial myxedema occurs on the lower extremities, on the anterior aspects of the legs. It can spread to the feet. Lower extremities appear waxy in color and have hardened areas described as orange appearance. Can extend into the trunk, upper extremities, face, chest, neck, back, and ears. Ophthalmopathy. So with the eyes, you would have eyelid retraction, proptosis, and conjunctival exposure. Proptosis is forward displacement of an eye or bulging eye. You see the lady with the bulging eyes is hyperthyroidism. Abnormal protrusion of the eyeballs. Exophthalmos is what that's called. Also eyelid retraction, proptosis, conjunctival exposure. What lab and diagnostic tests are performed for a client with hyperthyroidism? You do a lab assessment and assess T3, T4, TSH, high levels of T3 and T4. High levels of T3, better indicator of hyperthyroidism than T4. TSH, decreased indicates hyperthyroidism. TSH can also be decreased with secondary hypothyroidism. Ultrasonography, so you could do ultrasound of the thyroid. Electrocardiography, heart axis thyroid can cause tachycardias, dysrhythmias, as well as a P and T waves. And common for hyperthyroidism to have atrial fibrillation. What lab and diagnostics are performed for this client with the hyperthyroidism? Well, they can do the thyroid scan, evaluate size, shape, and position. Client receives radioactive isotope when external probe measures the amount the thyroid absorbed. Areas where the isotope was absorbed are noted as hot and warm, and areas of decreased absorption are cold. Should not be done with and is contraindicated in pregnancy and recent exposure to iodine-containing dyes. Thyroid or iodine-containing medications withheld for 6 weeks. Very short half-life of radioactive substance. No precautions unless high doses of radioactive substance is required. Results of thyroid scan, non-functioning areas, presence of lymphoma, thyroiditis, cyst, or carcinoma. Thyroid nodules can represent toxic goiter or benign adenoma. We're up to slide 10 in the thyroid. Medications prescribed for hyperthyroidism. You have antithyroid agents such as PTU, which is propylethiouracil. Also, this would be, you can do gastric tube, or it prevents production of more T4 and T3 in the thyroid and blocks the conversion of T4 to T3 outside the thyroid. You have methimazole, tapazole, 120 milligrams given in 20 milligram increments by mouth or via gastric tube, prevents production of more thyroid hormone. Iodine, such as Lugol solution, saturated solution of potassium iodide, Pima, SSKI, 10 drops, can do by mouth. This blocks release of stored thyroid hormone from the thyroid gland. You can also do glucocorticoids, dexamethasone, Decatron. This blocks conversion of T4 to T3, and along with hydrocortisone, 100 milligrams IV every 8 hours, blocks conversion of T4 to T3, and then beta blockers they use for hyperthyroidism. It's propranolol Inderal, which is IV. Then they have by mouth or gastric tube. And they also have esmolol, Brevibloc injection. This reduces the beta blockers to reduce symptoms of tachycardia, tremor, restlessness caused by a heightened response to catecholamine and blocks conversion of T3 or T4 to T3. So methimazole is mostly used now. It's because of its longer duration, once daily doses, that has a rapid efficacy. That is listed under an antithyroid agent. Lower incidence of side effects with methimazole. Iodides are for short-term use only. Inhibits release of thyroid hormones. Typically taken 1 hour after antithyroid medication. Administer this liquid and must be mixed with juice or another liquid to mask the flavor consumed with a straw because it will strain the teeth. This solution should not be used for pregnant or nursing moms. Third class of medications for hyperthyroidism is glucocorticoids. It blocks conversion of T4 to T3. Beta blockers used to treat the sympathetic nervous system Effects associated with hyperthyroidism. Important is it counteracts effects of increased thyroid hormones, but do not alter the level of hormones in the body. This is when you use beta blockers. So it's treating the symptoms. It doesn't alter the hormone. What medications are prescribed? Continued is radioactive iodine therapy, which destroys some of the hormone-producing cells. 1 dose may be sufficient, but may need more and not used with pregnant women. Degree of thyroid destruction varies and can require lifelong placement once destroyed. Monitor regularly for changes in thyroid function. When undergoing radiation, continue to take antithyroid medication. Continue taking that antithyroid medication while undergoing radiation therapy. With radiation therapy, you can't use it with pregnant women. You have to stay 1 meter away from pregnant individuals, infants, and small children. Limit contact to no more than 1 hour daily. Implement radiation precautions. So when you're on radioactive iodine therapy, contamination from saliva should be avoided. Do not share a toothbrush. Do not share utensils, paper plates, and plastic utensils. Use disposable food service items. Do not use the same toilet for 2 weeks. Sit down to prevent splashing of urine. Flush toilet 3 times after urinating or defecating. Take a laxative 2 to 3 days to get rid of the body of stool contaminated with radiation. Wear clothing that is washable. Wash clothing separate from others. Run the washer for a full cycle after running contaminated clothing. What should be included in the plan of care for a client with hyperthyroidism? Minimize client's energy expenditure. Provide calm environment, dark room, decreased temp of room. Assess mental status. Monitor vital signs, nutritional status, intake and output, and weight. Report temperature increase of 1 degree to provider. This is indicative of an impending thyroid crisis. 1 degree increase in temperature. Exophthalmos, the bulging eyes. Then you have to provide eye protection. Monitor ECG for dysrhythmias. Avoid excessive palpitation of thyroid gland. Administer antithyroid medications. Surgical management for hyperthyroidism could be a thyroidectomy, which absence of good response to drug therapy would indicate necessity of the surgical removal of thyroid. You could do a subtotal thyroidectomy, remaining tissue supplies enough thyroid hormone. Total thyroidectomy, client will need lifelong thyroid hormone replacement therapy. Post-op care, place patient in semi-Fowler's position. Monitor for respiratory distress from compression of trachea due to hemorrhage or edema. Respiratory distress usually occurs in first 24 hours after tracheostomy. Supplies immediately available must be on humidified air or oxygen. So you have to have trach supplies by the bed because they could have respiratory distress, which could occur usually in the first 24 hours. Must be on humidified air or oxygen. Assist the patient to cough and deep breathe. This is all post-op thyroidectomy. Provide oral care and suction as needed. Patient could also sustain from the surgery laryngeal nerve damage. Have clients speak as soon as awake and every 2 hours to assess this, if they can speak, or to see if there's laryngeal nerve damage. The patient can develop hypocalcemia and tetany. This is due to the parathyroid gland being damaged intraoperatively, so that's a risk. Parathyroid glands are located behind the thyroid, so how would you know if they're suffering from low calcium, hypocalcemia? They might verbalize periorbital or extremity tingling. They could have muscle twitching, positive Chavostic or Trousseau sign. Replace with IV calcium gluconate or calcium chloride immediately. Available for low calcium. You would want to supplement that to avoid this low calcium. What is a thyroid storm? Sudden surge or large amounts of thyroid hormones into the bloodstream. This causes greater increase in body temperature. It's a medical emergency with a high mortality rate. Causes of thyroid storm: infections, especially of the lung, thyroid surgery in patients with overactive thyroid glands, stopping medications given for hyperthyroidism, too much thyroid medication. These are all causes of thyroid storm, which is the medical emergency. Treatment with radioactive iodine, pregnancy, heart attack or heart emergencies. This is all rare and dangerous results from high levels of thyroid. The pathophysiology: hyperthyroid state, precipitating factor, increase in thyroid hormone, shift from protein-bound to free hormone, sudden increase in metabolism, exaggerated side effects of hyperthyroidism, which results in end organ damage. Precipitating factors: increases thyroid hormone, then metabolism, then exaggerated signs of hyperthyroidism, possible end organ damage. What separates hyperthyroidism from thyroid storm is the patient has hemodynamic instability with the thyroid storm, not with hyperthyroidism. What assessment findings and organ dysfunction can occur in a client experiencing a thyroid storm? Symptoms present would be delirium, congestive heart failure, congestive hepatomegaly, respiratory distress, extreme tachycardia or atrial fibrillation, chest pain. Liver damage and jaundice may occur from congestive heart failure or possibly from a direct action of thyroid hormone on the liver coupled with malnutrition. Fever and vomiting may produce dehydration and prerenal azotemia. Abdominal pain may be a prominent feature. Temperature may rise alarmingly, increased temperature. This is thyroid storm, slide 16. What should be included in the plan of care for a client experiencing a thyroid storm? Cardiac monitoring for dysrhythmias, cooling measures, administer acetaminophen for the fever, cool sponge baths, ice packs or cooling blanket. Administer medications for thyroid storm, thionamides, methimazole or propylthiouracil, sodium iodide Lugol's solution 1 hour after thionamide medication. You can use beta blockers, glucocorticoids. If adrenal insufficiency is expected or to treat shock, IV fluids, supplemental oxygen is needed. So then we're moving on to hypothyroidism. This ends hyperthyroidism.